Swayam Prabha. Digital India. Educated India.
Okay, I am Dr. G.C. Poonima, Professor and Head, Department of Anatomy, Mysore Medical College and Research Institute, Mysore. Welcome to this session on thalamus. Today I am going to talk about the thalamus. So, in the neuroanatomy session, we start with a clinical case. A man, 60-year-old man, developed weakness of his left leg, presented with the paralysis on its left leg and weakness of the muscles in the left arm. On examination, there was increased muscle tone, exaggerated tendon reflexes on the left side of the body. He also exhibited spontaneous jerky movement of the left leg, intentional tremors on asked to touch the tip of the nose. After 3 or 4 days, he complained of agonizing pain down on his left leg, even on the slightest touch of the bedsheet. So, with this case, we will start thinking what is the reason behind the person developing these types of symptoms and signs, which part of the brain is involved, and why are these symptoms and signs are exhibited. The learning objectives are: describe the boundaries of dorsal thalamus, describe the parts and gross relation of dorsal thalamus, describe the nuclei and connections of dorsal thalamus, discuss the clinical anatomy of dorsal thalamus. It's divided two major parts of it's a part of the diencephalon, which is divided into two parts, the pars dorsalis and the pars ventralis, by the hypothalamic sulcus. The pars dorsalis has the dorsal thalamus, which we usually call it as the thalamus, the metathalamus and the epithalamus. Below the hypothalamic sulcus, we have the subthalamus and hypothalamus. The thalamus is a part of the diencephalon which is situated cranial to the midbrain, and it is completely surrounded by the cerebrum. In the regular dissection, we do not see, when we see the superior lateral surface or the medial surface, the thalamus is not being so visible. But when we go to the base of the brain, it is being exposed in the interpeduncula fossa. This is a mass that you see on either side of the third ventricle, which divides the thalamus, especially the whole of the diencephalon, into two equal halves. It is a subcortical, the thalamus is a subcortical grey matter, ovoid in shape, and it is a relay station for all the sensory and motor modalities. It extends anterior-posteriorly, which is 4 centimeters, vertically it's 4 centimeters, and the transversely it is 4 centimeters. The external features, it has two ends, anterior end and posterior end, and it has 4 surfaces: medial surface, a lateral surface, a superior surface and an inferior surface. And this is the third ventricle, it is enclosing it. On the lateral side, it has a lateral ventricle. The thalamus is placed obliquely before backwards. So, it is placed before backwards, running backwards and laterally. The anterior end is pointed. The posterior end is wider, separated from the pineal gland, the superior colliculus and the habernacular triangles. In the midline, it is attached by a part of the grey matter called as the interthalamic connections. It forms the lateral wall of the third ventricle. So, this slit what we are seeing is the third ventricle, and it forms the lateral wall, and it forms the central portion of the lateral ventricle. The blue area is the lateral ventricle, it forms the central portion of that. So, these are the two ends and enclosing the third ventricle on the medial side and the lateral ventricle on the lateral side extending anterior-posteriorly. Then, the extent and relations of the thalamus, the anterior end is narrow, and it is posterior to the interventricular foramen. The posterior end is broad, it overhangs the pulvinar with which the medial and lateral geniculate bodies are present, and it overhangs the superior colliculus with the brachium. The superiorly, the relation, this is the superior surface. So, it is divided into lateral part and the medial part. In the lateral part, it forms the central part of the lateral ventricle. Medial part from anterior-posteriorly, it is separated by the tela chordae, the stria terminalis and the thalamostriate vein. The inferior surface, which we cannot see in this view, is fused with the subthalamus, and the posterior end of the inferior surface is free. The lateral part, it forms the boundary of the posterior limb of the internal capsule is being present. So, the thalamus is divided into number of nuclei. It also contains, most of it is grey matter, no doubt about it, but however, there is a small amount of white matter that is seen, and this white matter that enclosing within the thalamus is called as intramedullary lamina. And laterally also it has got a bit of white matter called as extramedullary lamina. So, this divides this ovoid shaped subcortical grey matter into number of nuclear complexes. So, now let us deal with what are the various nuclear complexes that is being present within the thalamus. The thalamus, this is the intramedullary lamina. So, between the two limbs of the intramedullary lamina, we have the anterior nucleus, and it is broadly divided into dorsal and ventral nuclear complex. The largest of it is the ventral nuclear complex. So, in the medial side, between the limb of the vertical limb of the intramedullary lamina, we have the dorsal nuclear complex, which is very large and within which is divided into dorsal medial and the dorsal ventral part. Then we have the ventral nuclear nucleus, which divides into a dorsal part and a ventral part. So, this dorsal part, which we have craniocaudally, which I have numbered it as 5, 6 and 7, are the dorsolateral, dorso-posterior, and then this part is a pulvinar part. Then the other nucleus is the ventral anterior, ventral lateral and ventral posterior nucleus, which is again subdivided into ventral posterior lateral and ventral posterior medial. There is also the midline nucleus, centromedian nucleus, the extramedullary nuclei is being present, which you call it as a reticular nucleus in the extramedullary lamina on the lateral aspect. So, this is the nuclear complex that is present within the thalamus. So, now let us talk about the thalamic nuclei, the various afferents of each and efferents of each nuclear complex with their functions. So, now let us talk about the anterior thalamic nuclei, which is present between the two limbs of the intramedullary lamina. So, it sends afferents to the mammillary body of the hypothalamus and to the cingulate gyrus in the cerebral cortex. It receives efferents from the cingulate gyrus. The main function of this anterior nucleus is attention and the recent memory, and it is a part of the Papez circuit. Then we have the dorsal medial nuclear complex. The afferents is connected to the hypothalamus, the amygdaloid body, the corpus striatum and the piriform lobe, a part of which will be a part of the limbic system. Then the efferents is connected to the prefrontal cortex of the cerebral hemisphere, and then hypothalamus and other thalamic nuclei. What the function is the emotional feelings, then the mood changes, the personality of the persons are all handled by these nucleus. The overall person's behavior is handled by the dorsal medial nucleus. Then we have within this as a dorsal lateral and the dorsal posterior nucleus, where it is connected to the cerebral cortex and other thalamic nuclei. So, it is efferents is to the parahippocampal gyrus, the cingulate gyrus and the superior parietal lobe. The main function of it is to assimilate and integrate all the sensory information. Next, we have the two nucleus, the ventral anterior and ventral lateral nucleus. The ventral anterior nucleus, the afferents is from the globus pallidus, which is a part of the basal ganglion. Through the subthalamic fasciculus, it receives the afferent, and the efferent is the motor associated area number 6 and 8 on the cerebral cortex. It influences the motor activity, both pyramidal and extrapyramidal system. Whereas the ventral lateral receives the afferents from the dentate nucleus of the cerebellum and also the red nucleus. The efferents are given to the associated motor areas, and all the functions of the cerebellum like the balancing, the muscle tone are all managed by this nucleus through the dentate nucleus. Then you have the other nucleus that is present in the thalamus. Within the intramedullary lamina, we have the intralaminar nucleus and also the centromedian nucleus. So, this afferents is from the brainstem reticular formation. The efferents are sent to the all other nucleus of the thalamus, and then mainly involved in the painful stimuli at the thalamic level. The painful stimulus can be felt at two levels, one at the thalamus and one at the cerebral cortex. So, this nucleus will handle the painful stimulus which the person experiences at the thalamic level. Then the reticular nucleus, which is present at the medullary, extramedullary lamina on the lateral aspect of the thalamus. So, this also afferents it receives from the brainstem reticular formation, efferents to the whole of the cerebral system cortex, it is been sending the efferent. So, it forms a part of the ascending reticular activating system, the alertness of the person to the environment, to the within the functions of the body is being managed by this nucleus through the reticular formation. The next one is the medial geniculate body. It is a third order neuron of the ascending pathway of the auditory impulses. So, afferents it receives from the inferior colliculus and also the lateral lemniscus nucleus. Then it is relayed into the efferents to the auditory area in the superior temporal gyrus, the area number 41 and 42. The main function is it is a relay station for all the auditory impulses. Then you have the lateral geniculate body. So, it receives the afferents from the optic tract, both crossed and uncrossed fibers from the retina, the temporal and nasal fibers are relayed in this one, and from there it is relayed to the cerebral cortex in the primary visual cortex, area number 17 in the occipital lobe. So, it is a relay station for visual impulses. So, the other thalamic nuclei and its connections are the ventral lateral nucleus. Just like the ventral anterior, this receives the input from the cerebellum and from the red nucleus, and efferents back to the cerebellum and red nucleus influences the various motor activity and muscle tone, the maintenance of posture. All this is influenced by this nucleus. Then the VPM nucleus is a ventral posterior median nucleus. It receives the trigeminal lemniscus, which is the ascending fasciculus from the head and neck region, the crossed fibers from the opposite side of the head and neck region, carrying all the sensory information, and it relates to the primary somatic area number 3, 1 and 2. So, the general sensation of the head and neck region. The gustatory fibers, that is the taste sensation, is also relayed in this trigeminal lemniscus from in the VPM nucleus. From there, it is in the lowermost part of the primary somatic area of 3, 1, 2. You carry the sensation of taste. Next, we have the VPL nucleus, which is the ventro-posterolateral nucleus, which has a medial and spinal lemniscus from the limb region, both upper and lower limb, also the trunk region, the crossed fibers of general sensation of touch, pain, temperature, stereognosis, 2-point discrimination. All these sensations are carried, the efferents to the area number 3, 1, 2 is a primary somatic sensory area in the cerebral cortex. So, it is a common sensation of all the other modalities from the different parts of the body. So, this one with a brief summary of what has been done till now is the thalamus. It is a ovoid grey matter. It is a subcortical matter which is submerged in the deep part of the cerebral cortex, having an anterior and posterior end, medial and lateral surface, superior and inferior surface, divided into number of nuclear complexes by the intramedullary lamina as a ventral anterior nucleus, dorsal medial nucleus, then ventral divided again into the lateral posterior, lateral dorsal, ventral anterior, ventral lateral and ventral posterior, intralaminar, centromedian nucleus, pulvinar, medial and lateral geniculate body. So, in the next part of our discussion, we will talk about the thalamo-cortical connections. So, what are these connections? The different parts of the nucleus, how it is being relayed in the cerebral cortex. So, we have the anterior nucleus, which is in the anterior part relayed in the cingulate gyrus, which is seen on the medial surface of the cerebral cortex. Then we have the ventral anterior and ventral lateral, which relays in the associated motor areas, area number 6 and 8. We have the dorsolateral nucleus, which is relayed in the superior parietal lobule. The median dorsal nucleus, it is relayed in the prefrontal cortex area, both on the superior lateral surface and on the medial surface. The pulvinar, which is a continuation of the medial and lateral geniculate body, relays in the associated visual area. Then we have the ventral posterior nucleus, which is relayed, which is a VPM and VPL nucleus, relayed in the primary sensory area 3, 1, 2. The VPM nucleus is relayed in the lower part, carrying the sensation of taste and also the general sensation to the head and neck region. The medial geniculate body is relayed in the superior temporal lobe, which is a primary auditory area. Whereas the lateral geniculate body is relayed in the primary visual area in the occipital lobe. So, these are the thalamo-cortical connection, how the various nucleus of the thalamus is relayed into the different parts of the cerebral cortex, both on the superior lateral surface, the medial surface and also on the inferior surface. Which next one, we call it as a thalamic radiation, the ones that is passing from the internal capsule. They are anterior thalamic radiation, the superior thalamic radiation, the inferior thalamic and posterior thalamic radiation. The anterior thalamic radiation is passing through the anterior limb of the internal capsule, mainly carrying the fibers to the prefrontal cortex, the associated motor areas and the motor areas and also the sensory areas, that is the medial dorsal, ventral anterior, ventral lateral, the VPL and the VPM nucleus. So, these radiations are carried to the anterior thalamic. The superior also carries the medial dorsal, then the lateral dorsal and lateral posterior. The inferior thalamic radiations is through the sublentiform part of the internal capsule, it carrying the medial geniculate body fibers. Whereas the posterior radiation is from the retrolentiform part of the internal capsule, carrying the fibers from the lateral geniculate body. So, these are the thalamic radiations after from the thalamus, then the internal capsule and then to the cerebral cortex, how it is distributed along with the various other ascending and descending fibers, these thalamic radiations, how it is being distributed in the internal capsule. So, the next part in the overall view of the functions of the thalamus is, it is a chief sensory integrating center and also the relay center of all sensory pathways except the olfaction directly into the specific cortical areas. It also an integrative center for the motor functions from the cerebellum and basal ganglia, and all through the ascending reticular activating system. The thalamus reticular component participates in the maintenance and regulation of wakefulness, attention, including the emotional response to the sensory input, especially the alertness. By receiving the impulses from the hypothalamus and it projects to the prefrontal and cingulate gyrus, it participates in the determination of the mood, the personality of the person, all these factors. Then it also has a role in the recent memory and emotional behavior of the person. Now we come to the blood supply of the thalamus. So, as we are all aware of, the cerebral cortex is supplied by three sets of arteries, that is mainly from the internal carotid and the basilar artery, each giving a anterior cerebral artery, middle cerebral artery and posterior cerebral artery. Each of these arteries has a general planning of the blood supply. It has a cortical branches, the perforating branches and the choroidal branches. So, coming to the blood supply of the thalamus, it is supplied by anterior-medial, anterior-lateral group, posterior-medial and posterior-lateral group, and these arteries that is supplying will be the thalamotuberal artery, which are the perforating arteries supplying the substance of the thalamus on the posterior-medial aspect. Supply the anterior and the medial parts of the thalamus. There is in the posterior lateral group is the thalamo-geniculate branches, which is a branch from the posterior cerebral artery which supplies the posterior part and the lateral part of the thalamus. It not only receives the branches, but there are other arteries which participate in supplying the thalamus, like posterior communicating artery, the anterior choroidal artery, then we have the middle cerebral arteries. The venous drainage, like all the venous drainage in the thalamus, is drained by it finally drains into the intracranial venous sinuses. It has 3 sets of deep veins, that is the thalamostriate vein draining the thalamus and the basal ganglia, the septal veins draining the septum pellucidum, the choroidal veins draining the choroid plexus. They all drain into the internal cerebral vein, and which in turn, they are paired veins, which in turn drains into the great cerebral vein. Finally, this drains into the straight sinus. These veins of the thalamus are valveless, they are very thin walled, and they do not follow the arterial pattern. So, what are the clinical conditions related to this thalamus? Thalamus is an important relay and an integrative center. So, it can be invaded by any space occupying lesions or degenerative changes due to hemorrhage, thrombosis of the arteries supplying the thalamus. So, because of this area, the effect of this as the profound effect is seen when there is a disease in this area. The first one is the thalamic syndrome of Digery-Rousey. It is due to the arterial occlusion of the thalamo-geniculate branch of the posterior cerebral artery, which supplies the posterior lateral side of the thalamus. So, if this arterial occlusion occurs in this region, so what are the clinical symptoms and signs which we can expect? So, they can span sensory loss on the contralateral side of the body because of the involvement of the ventro-posterior nuclei, which is the chief sensory nuclei which receives all the sensory inputs. So, then there is a thalamic pain. The patient experiences severe, persistent, paroxysmal, intolerable pain. This is due to the involvement of the intralaminar and other non-specific nuclei. It may also involve sometimes if the midbrain or the internal capsule is involved, there is extensive motor and sensory defect leading into intentional tremors, loss of muscle tone leading into choreostasis with ataxia. Then there is a condition called as a thalamic hand. So, in this one, because of there is a contralateral hand is held in an abnormal position. So, what happens in this condition is the forearm is pronated, the wrist is flexed, metacarpophalangeal joint is flexed, interphalangeal joint is extended. Though the fingers can be moved actively but slow, which is due to the altered muscle tone in different group of muscles. The person can move the fingers, but the activity becomes very slow because each group of muscle has different muscle tone, and so the activity will be slowed down, but however movement is possible and it will be held in this position. If the internal capsule becomes involved, it becomes called as a transient hemiparesis, involvement of the internal capsule. If the lateral geniculate body, if the posterior most part is involved, the involvement of lateral geniculate body, then it leads to a condition called as homonymous heminopia. There is another condition called as phantom limb, where the person feels he is unable to locate, he or she feels unable to locate the position of the hand or limb. He develops this kind of illusion that he does not have a limb. This is because of the thalamic lesions. So, coming back to our case, what we had told about the case has the 60-year-old man, the development of the weakness in his left leg, paralysis of the left leg and weakness of the muscles of the left arm. So, there is an increased muscle tone, exaggerated tendon reflexes on the left side of the body. He exhibited spontaneous jerky movements of the left leg, intentional tremors on touching the tip of the nose and agonizing pain even on the slightest touch. So, with these conditions, some signs and symptoms, how do we correlate it? The paralysis may be due to the involvement of the internal capsule part, the thalamic radiations, the increased muscle tone because of the cerebral part is being involved, that is the ventral anterior and lateral nucleus may be involved. The jerky movements, the intentional tremors is because of the ventral anterior and ventral lateral nucleus. The agonizing pain because the thalamic pain is being felt at the intralaminar nucleus and in the centromedian nucleus. So, if these nucleus are lesion has occurred, then even though the slightest touch, the patient will experience an agonizing pain. Also, the behavioral pattern also can be seen a change if there is an involvement of the dorsomedial nucleus, if the prefrontal cortex is being involved. So, what we have is the specific relay nuclei connecting to the specific motor and sensory area of cerebral cortex, which are the ventral tire and geniculate bodies. Then the thalamic other nucleus is association nuclei, where the association areas of the cerebral cortex is involved with the lateral and medial dorsal nuclei and lateral posterior nucleus. Then we have the non-specific nuclei as not specific to any sensory modalities. Almost all sensory modalities are involved like intralaminar, the midline nucleus and the reticular nucleus. So, on the whole, the thalamic functions can be classified as a specific relay nuclei, the association nuclei and the non-specific nuclei. So, summary of this one, we will pick a quick recap. So, this is the thalamus, which is a subcortical ovoid shaped grey matter which extends anterior-posteriorly enclosing the two ventricles, that is a lateral ventricle and the third ventricle. It is having two ends, an anterior end, posterior end, medial surface, lateral surface and the superior surface and inferior surface. This subcortical grey matter has little bit of white matter which we call as intramedullary lamina, extramedullary lamina. The nucleus divided over here is the anterior nucleus, the dorsomedial nucleus, lateral posterior and lateral dorsal nucleus, the pulvinar, the ventral anterior, ventral lateral and ventral posterior, which is divided into ventral posterior, lateral and ventral posterior medial. There is a centromedian nuclear complex, the intralaminar nuclear complex and the reticular formation. We have the medial and lateral geniculate body. Then we have the thalamo-cortical connections, the various nucleus of the thalamus that is connected to the different areas of the cortex. We have the anterior nucleus is connected to the cingulate gyrus, it is both afferents and efferents are connected. You have the medial dorsal nucleus, the afferents are efferents connected to the prefrontal area both on the superior lateral surface and the medial surface. The ventral anterior and ventral lateral is connected to the associated motor areas on both the surfaces of the cerebral cortex. Then we have the VPM nucleus which is VPM and VPL to the specific sensory cortical area. In the upper part is a VPL nucleus, in the lower part it is a VPM nucleus conveying the trigeminal lemniscus and the gustatory pathway. Then the pulvinar is connected to the inferior And also on the superior part, we have parietal lobule, you have the lateral dorsal and the lateral posterior nucleus. The medial geniculate body is relayed in the superior temporal gyrus, which is the primary auditory area. The lateral geniculate body is relayed in the occipital cortex, which is a primary visual area. Then we have the internal capsule, which conveys the 4 radiations. These 4 radiations are the anterior thalamic, the superior thalamic radiation, the inferior thalamic and posterior thalamic radiation. Now coming to the blood supply, the perforating arteries supplying the thalamus both on the medial and lateral surface and anterior and posterior part are the thalamotuberal arteries and thalamo-geniculate arteries, which are the branches from the posterior cerebral, posterior communicating and also the posterior choroidal and middle cerebral arteries. Then the venous drainage is 3 sets of veins, the thalamostriate vein, the choroidal vein together form the internal cerebral vein, which forms the great cerebral vein draining into the straight sinus. So overall, it is a part of the diencephalon which encloses the third ventricle. It is a major relay station for the sensory modalities of all the ascending tracts go to the primary sensory area. It also has inputs from the subcortical motor nuclei, also from the cerebellum. It is divided into an anterior, medial and lateral group nuclei. The anterior and medial group nuclei becomes a part of the limbic system. The ventral group is a part divided into VPL and VPM nucleus because it receives the specific somatosensory pathway from the spinal cord and brainstem. The intralamina nucleus receives from the reticular formation, projects into the cerebral cortex. So, there are 4 thalamic radiations which through the internal capsule projecting into the cerebral cortex. So, this is the overall view about the thalamus, its various nuclear components, its various connections receiving from the lower part of the brain and how it has got the projections into the cerebral cortex and the various clinical features it represents if there is a lesions in these nucleus. Thank you.